Hey everyone, welcome back to XGate Dental. I'm Emmanuel Kadosh, and we are here to discuss new procedures in the field of dentistry. We will provide interesting new cases to exhibit how doctors use our products to solve complicated dental cases, so let's get started. Today's going to be a long one and possibly even a two-parter. This is how one of our patients came to the clinic. You can see she had one upper bridge, one lower bridge, and some of the teeth, almost all of the teeth under the bridge are problematic. She has caries, inflammation, and a bunch of other issues. And in addition to all of that, you can see that the aesthetic is not really great either. You can see that the height of the canines is different and the height of the central incisures, and you can see the second incisures are different in sizes. It's a PFM bridge. You can see that the central line is not perfectly aligned. You have a lot of small problems, but the main reasons why we want to change the bridge and extract the teeth and do implants is not the aesthetics. It's the caries and the teeth under those bridges. First of all, because her relations are quite correct, the vertical dimensions of the occlusion is fine. We want to change the bridges one by one. We don't want to do everything from the start. This way we can use the vertical dimensions that she has right now, and the final bridge will be with some of the same vertical dimensions. We're keeping the relations she already had. The relations is not something that we want to change. She also got used to those relations. She had these bridges for a long time. She wanted to stay with them. We just need to extract the teeth and to change the bridges to new bridges, and we want the new bridges to be in the same relations. So this way, it's much simpler for the doctor to do it on one bridge at a time and not everything all at once. You can see that we extracted all the teeth. We placed implants, and you can see that all in all, we have 8 implants. The implants are quite parallel. We don't think that it will be a problem, and we placed multi-units right after the implantations, and then we took impressions. Now, it takes some time to make a bridge. So in this case, we released the patient with healing caps for about a day or two until we made a new provisional bridge on those multi-units. The second thing we'll see is the healing caps. You can see all the healing caps, all of the multi-units. You can see it's still bleeding a little bit. This is how she went home for 2 days. We tried to schedule these operations so that everyone, the technician, the doctor, the surgeon, will be available, so she'll get the provisional bridge as fast as possible. And if it's done in the morning, in some cases by the evening, you can already have a bridge. This is the bridge. You can see that the picture was taken after. It took some time to heal, and you can see that the gingival color is somewhat better. You don't see all of the blood and the inflammation that was there before because of the surgery. You can see that the relations are the same as they were before, and this was taken about a week or so after the operation. You can still see that there's no complete healing of the gingia, but everything is much better. Now we would send her home for about 3 to 4 months, and then when she'll come back, we start changing the lower bridge. Also, extract the teeth, place implants, and make a provisional bridge. Same procedure as before. After 4 months, you can see she came with a bridge, and you can see the main reason why her teeth were extracted in the first place. You can see that there's no hygiene at all, and you can see all the plaque around the crowns. You can see inflammation around the crowns, and it's not what we want to see after 4 months, after the healing process was done. We want to see clean crowns. Right now, it's not the ideal situation to see after you're sending the patient home and they come back after a few months. You can see the screw channels, and you can see the material of the screw channels is a little bit different color than the material of the original bridge. And you can see that the screw channel will go off from the buccal part. So in this case, maybe we need to consider changing the straight multi-units to angulated ones. Now we place the implants on the lower mandible in 2 steps. The first step, we took off the bridge and we placed about 4 to 5 implants. And you can see that we have an implant around the second molar. We can have an implant around both canines and around the second premolar and second molar also, and we returned the PFM bridge that she had before, and we gave those implants some time to osseointegrate. Then in the second stage, we've added some more implants because 5 implants for the lower jaw is a little bit problematic. You can see that you have a large span, and if we want to have a ziconia bridge, you can't have 1 implant around the second molar and the second implant around the canine. Nothing will hold, and you'll have a discementation, and the bridge will break, and obviously we don't want that to happen. In the second stage, we've added some implants around the extraction, and you can say that one of the implants is angulated because of the mental nerve. We want to go around the mental nerve so that the implant has a messy angulation. And we know that in this implant, we have an angulated multi-unit that will correct the angulation of the implant like in the classical 4. You can also see the sockets of the extracted teeth. You can see the scan abutments and you can see a little bit of blood in the scan abutments. We took an impression from all of the scan abutments, and in the second stage, we want to construct some material to have relations for the lower bridge, for the lower part of the bridge. In this case, after we took impressions only from the scan abutments, we will take impressions from the scan abutments with some material on them. Here you can see that we took off some scan abutments and we've added on some of the scan abutments composite material. The composite material is in occlusion, and you can see that the height of the scan abutments is exactly 6 millimeters. This is probably the smallest height for the restoration that you want to have. In the interior part, you have much more. You can see the height of the composite material. This is the bridge that we took off. You can see that the teeth were just rotten. You can see parts of the teeth, the post and core, everything is glued to the teeth. There was literally nothing left from these teeth. So it's not for the aesthetical part that we took it off. It's for the biological part. This is the new bridge, and you can see that in the upper bridge, she started brushing her teeth a little bit better. You can see the occlusion, and you can see that it's not bad, just a little bit of interface. You can see around the canines in the interior part that you can correct a little bit. You can see that she has contact also on the second molar. A lot of contact points, which is quite good, not perfect, but the central lining, all of the restoration itself, the aesthetical part, the functional part, is not bad for provisional restoration for the first bridge that you have after you took impressions on the implants that were immediately placed and immediately restored. It's not easy to get this type of contact. Now, after some healing, we can see that the gingiva is starting to form up, and you can see that the contactivity of the crowns. And we also made a new temporary bridge, and you can see that the occlusion is so much better. Maybe we would need to make some corrections of the central line. You can't have one temporary bridge and in this one temporary bridge get everything perfect and go straight to the ziconia. It's unrealistic. It's a process, and a lot of times things can happen that you can't anticipate, and you could have some misalignment in the impression taking process because of the blood, the clots, the gingiva. Anything can interfere with the scanning process. The main point is that you're not doing it all in one visit. You need to take your time to make it perfect in order to get a perfect result in the end. This is still not a perfect result, but it's getting closer. You can see that after some time, we took off the bridge, and you can see that the healing of the gingiva, that you have indentation for the teeth, and that it will look like the teeth coming out of the gingiva. It's something you want to form in the process of the temporary bridge. It's also something that's quite important. Now, you can see the third temporary bridge that we had. This bridge, when she smiles, you can see the upper teeth. The incisures are almost the same size. With implants, sometimes it's difficult to have the same size of the incisures because on one of them, she had a long crown, and on the second one, she had a short crown. And you need to compensate for all the things that you had before. And the same thing for the implants on the lower jaws. So we took those bridges, and in the end, she was satisfied with, and the smile and lip line and the aesthetical central line, everything was fine. And now we want those bridges to be made from ziconia. So we took the bridges, and because it's a bridge on the 14th tooth from the monolithical ziconia, the best thing to do is not to melt the sleeves on the model or in the laboratory. We want to compensate for the inaccuracies that you have when you center the ziconia. You mill the ziconia from uncemented material, and then you cement it to a much harder material that shrinks and that has some deformation in the cementing process. This is why the process of the cementation of the sleeves we're doing in the mouth. We're taking the sleeves and we're putting them inside the bridge and cementing them 1 by 1 or 2 by 2 inside the mouth. Because when you attach a ziconia bridge or screw retain bridge to multi-units to any construction, you want to have a passive fit. You want some kind of force that won't be applied in the multi-units or the implants. So this is a method of, let's say, prevention. If you'll cement them outside the mouth, all the inaccuracies will be the same and they'll stay. And then when you assemble the bridge on top of the implants, you have those forces that will be applied on the implants or on the screw or on the multi-units. Then there's less chance for problems with the implants, less chance for the ziconia to break. From our experience, this is probably the only way to have a full monolithical ziconia bridge that doesn't break down. What you see here is, first of all, we prepare the bridges and all of the sleeve with the screws, with everything prepared. Now, what we do is insert some of the sleeves, and we need for the slips to hold inside the cavity for the sleeve, right? So because if you just flip the bridge, everything will fall down. So we use toothpaste. We apply it on the sleeve and we hold the sleeve in place. So 5 sleeves, the posterior sleeve, we're holding inside the bridge using toothpaste. And now in the first place, we'll cement only the frontal 3. And then we screw all of the sleeves together. So we'll have a bridge inside the mouth with all of these sleeves, 3 cemented and 5 on toothpaste. You can see the contacts with these 3 sleeves and the 5 toothpaste. Later on, we'll take out the toothpasted sleeves and change the cementation process from toothpaste to real cement. And when we cement all of the sleeves, we want to take the bridges and we want to clean the residue of the cement. We don't want to put the bridge inside the mouth and keep it with all of the residue and inflammation. It's not cemented restoration, it's screw retained restoration. So we want to take it out, then we clean out the residue of the cement, and then you can see that in some places, feeding of the sleeves into the cavity for the sleeve is not perfect, but we did have a perfect occlusion. So why did it happen? This deviation when we do the impression. The technician placed the scan markers on the impression that we took. Then we milled the ziconia, and then the cementing process inserted some deviation. All of these deviations are going one on top of another, and then in the final process, you get some part of inaccuracy. If you didn't do it in the same way, you didn't see this inaccuracy. You just had internal forces in the ziconia bridge. And then after 1 to 3 days, maybe a couple of weeks, the ziconia will just crack, and then you'll see 2 parts of the ziconia. One is higher than the other. And here you see that you have a very small slot between the sleeve and the ziconia bridge. Right now you can take composite material, flow liquid composite material, just close it up and polish it to have it. So we just added some material here to close it, and this way you don't have any gaps for bacteria or different types of organisms. Over here you could see the same. Here are the residues of the cement that we had from before. Now later on, we'll close the gap where you can see most of the deviation on the posterior sleeve, because if you have inaccuracies in the center, the posterior sleeves are affected the most. This is why we screw the interior in the first place in order to see these deviations. The last bridge was the lower one. Now we can say that we have the same with the upper bridge. With cement, the angulated abutments, the angulated sleeves, and then in the second place, we'll cement the straight ones using the same method, the same thing as we talked about before. When we're cementing and you have some saliva or residue of the cement, you just clean it up a little bit. It's actually very easy. You can see in the posterior part that the gap is not very small. In this case, you wanted to make a ziconia bridge, and then you attach the ziconia bridge to the multi-unit, and you probably will have a problem. It's not a large deviation because it's in the modification. It's like a 0.1 or 0.2 millimeter. And all of these deviations are because of the cementation process in the modeling program. You need to position the scan abutment model on top of the real scan abutments. And when you scan the posterior teeth, it's sometimes hard to scan them, and you have gaps or places that didn't scan very well. So it's hard for the technician to position the scan abutment model on top of the scan abutments. And you can have some deviation there also. The higher the scan abutments or the multi-unit, you'll have the bigger deviation. You can just close it with composite material or composite material for tooth filling, and the same thing flowable. So it would go inside the slot, and then you just polish it and you have a perfectly fine ziconia bridge, full monolithical ziconia. You know that when you screw the ziconia bridge, you won't have any internal forces because it's cementation, when the cementation process was the cement didn't harden. So the sleeves are perfectly passive. They compensated on those inaccuracies and those interoral forces that could have been. That's all. You have 5 ziconia bridges with no gaps, nothing at all. Closed all the gaps with composite material, so when you're making a full ziconia bridge, the parts that close with the gingiva, it's better not to glaze because this way you minimize the retention of the plaque. The part that closes the gingiva for the upper bridge is the top part. You can see here the final bridges, the screw channels in the first molar. This screw channel later on will close, and we'll apply a little bit of composite material to correct the color of the screw channel. You can see the plastic pins that we closed the ziconia bridge with, and her final smile with different types of lightning. So in this, you can see that the bridge is a little bit whiter, and here a little bit yellower. But all in all, you can see that all over it is the same level. It's much better than what she had before. The midline is great, and the smile looks fantastic. Thank you everyone that joined in to learn some new and interesting information. Make sure to stay tuned for more, and of course, don't forget to subscribe, like, and follow. Thank you, and see you next time.